Welcome to the deep dive, and thanks so much for joining us today. Look, if you're on that demanding path of orthopedic residency, maybe gearing up for your FRCS or similar exit exams, we get it. Mastering complex topics quickly is, well, it's tough.
It really is.
So today, our mission is to really arm you with critical insights into two conditions that are, frankly, challenging but super common: adult dysplastic hip and femoral acetabular impingement, FAI. And we're basing this deep dive on the excellent Ortho-Made Simple Notes from mokyingren.sg. They were put together by Dr. Mok Ying Ren, a sports surgeon over at National University Hospital, Singapore. He got his FRCS back in 2022.
That's right. And understanding these, especially the nuances, it's not just about exam recall, is it? It's really about building that deep understanding for your clinical work, from the clinic right through to the OR. We want you to grasp the why behind it all.
Okay, great. So let's unpack adult dysplastic hip first. When we talk about this, what are the fundamental anatomical problems we should be looking for? Because it feels like it's more than just a shallow socket.
You've hit it exactly. It's easy to just think shallow socket, but adult dysplastic hip is really more of a syndromic deformity. It affects the whole joint.
Okay.
So acetabulum-wise, yes, typically retroverted, shallow. But the femur, it's often involved too. You might see it be more anteverted, pointing more laterally.
Right.
And coxa valga, that high neck shaft angle. Sometimes coxa magna, a big head struggling in that small socket, or even coxa plana, a flattened head. It messes with the joint congruity, increases stress.
So multiple femoral issues too.
Exactly.
Yeah.
And paradoxically, sometimes the head looks small relative to the socket. And then there's the soft tissues, often a thickened capsule, tight iliopsoas, adductors, hamstrings, even a shortened sciatic nerve. It all affects the mechanics.
Wow. Okay. That paints a much broader picture. Now, most of us jump to DDH, developmental dysplasia, as the cause. But what else can actually lead to a dysplastic hip?
That's a really good question for exams. The underlying principle is, well, you need that consistent concentric force from the femoral head for the acetabulum to develop properly.
Right. The pressure shapes the socket.
Precisely. So any condition that disrupts that force during growth can be a culprit. Think polio, cerebral palsy, sometimes systemic hyperlaxity, or even the aftermath of something like Perthes disease, where the head itself was affected early on.
Got it. So it's about that developmental force. Now, for exam prep, x-rays are just crucial. What are the absolute definitive features we should be spotting on an x-ray for adult dysplastic hip?
Yeah, imaging is your roadmap here. So on the x-ray, look at the acetabulum first. It'll likely look shallow. You'll see that reflected in a higher acetabular index or an increased angle of sharp.
Okay, shallow socket confirmed.
Then check the femoral head. Maybe coxa magna. Maybe it's not perfectly round, just doesn't articulate well. Or it could look small.
Yeah.
And almost always look for a disrupted Shenton's line. That's a big sign of subluxation.
Shenton's line, okay.
And the femur neck, usually a high neck shaft angle, so valgus. The femur shaft itself often looks narrow, small canal, and anteverted, with that lateral part kind of exposed. Those are really clear signs. So when a patient actually comes in and you suspect this, how do you approach the assessment? What's this triple assessment we hear about?
Right, the triple assessment is just a systematic way to cover all bases. First is the history. You need to ask specifically about any past history, DDH, polio, Perthes, CP, and crucially get a functional assessment. How does the pain affect their life, their activities?
Makes sense.
Second, the physical exam. You inspect, carefully look at their gait, any limp, do special tests like Trendelenburg for abductor weakness, measure for leg length discrepancy, check for stiffness, range of motion, and definitely do a Thomas's test for flexion contractures.
History exam. What's the third part?
Sorry, I should clarify. The triple often implicitly includes imaging as the third crucial component, which we were just discussing. History, physical exam, and imaging work together.
Gotcha. Okay, classifications. They can be a bit daunting under pressure. Can you walk us through the main ones for adult dysplastic hip? Why do they matter? Absolutely. They give us a common language and guide treatment. The two big ones are Hartofakidis and Crow.
Okay.
Hartofakidis basically describes how the femoral head articulates or doesn't with the true acetabulum. Type A, no articulation. Type B, a false socket is formed. Some true articulation remains. Type C, no articulation with the true socket at all. It's more about the anatomical severity.
Right, describing the joint itself.
Exactly. Then you have the Crow classification. This one measures how much the femoral head is subluxed and migrated proximally. It uses percentages based on head diameter. Less than 10%, 10, 15%, 15, 20%, and over 20%.
And that's more for?
Crow is really invaluable for planning arthroplasty. It helps predict things like, well, you need to shorten the femur, do you need to address a high hip center. Very practical for surgical planning.
That's a helpful distinction. Now, beyond those broad classifications, you mentioned specific X-ray angles and signs. These seem vital for diagnosis, especially telling dysplasia apart from, say, pincer FAI. Which ones must residents know?
Yes, these angles are fundamental. You absolutely need these in your toolkit. Let's break them down.
Okay.
For the acetabulum. Acetabular angle of sharp. Normal is 33-37 degrees. It's measured from the teardrop to the lateral sorsal, that sclerotic roof bit. Higher angle means dysplasia.
Angle of sharp, I got it.
Then the lateral center edge angle, or LCEA. Normal is 20-30 degrees. Vertical line from the head center to the lateral sorsal. But, and this is critical, it only counts if the head is properly seated and located.
Right, only if it's in the socket properly.
Exactly. Too small suggests DDH, too big might hint at FAI, overcoverage. Then there's a tonus angle, normally under 10 degrees. Medial edge to lateral edge of the sclerotic sorsal, again, only if and located.
Okay, tonus angle too.
For anterior coverage, you need the anterior CE angle, normally over 20 degrees. But this needs that special false profile view pelvis rotated 65 degrees.
False profile view, okay? Need to remember that one.
And finally, signs of acetabular retroversion, which you can see in both conditions. Look for the crossover sign, anterior wall crosses posterior on the AP view, and the visible ischial spine sign. Those two scream retroversion.
Crossover and ischial spine sign. Excellent. Now, before surgery, complex anatomy. What's the go-to investigation for detailed pre-op planning?
For really mapping out that complex 3D bone structure, especially in dysplasia, a CT scan, ideally with 3D reconstructions, is invaluable. It gives you that detailed roadmap plain X-rays just can't.
CT with 3D. Makes sense. Okay, let's switch to management. This is where it gets really interesting, right? The decision-making. How do we manage a young patient, dysplastic hip, but crucially no significant OA yet, thinking hip preservation?
Yeah, this is all about trying to head off arthritis. The big decision point is joint congruity, essentially how well the head fits the socket, even if it's shallow.
Congruity is key.
Right. If the hip is congruent, relatively speaking, you might consider arthroscopy, but really only for very mild dysplasia. And you have to be super aware of failure predictors, things like an LCEA under 15, tonus over 20, a broken Shenton's line. Ajay Shah's group highlighted these. Scope might not work well then.
Okay, so scope only for very select mild congruent cases.
Pretty much. If the hip is not congruent or coverage is clearly inadequate, then arthroscopy isn't the answer. The goal shifts to achieving better coverage, normalizing mechanics. That usually means osteotomies.
Osteotomies, like PAO.
Exactly. The Bernese periacetabular osteotomy, PAO, is the workhorse here. A powerful procedure, sometimes maybe a proximal femoral osteotomy, or even salvage osteotomies in really severe cases, but PAO is the main one for reorienting the socket.
And what about the older patient? OA has set in, preservation isn't really on the table anymore.
Yeah, for those patients with established OA, you're looking at arthroplasty, hip replacement. And here, that Crow classification really comes back into play to guide your planning. Well, a Crow 1 is relatively straightforward, normal hip center usually. Crow 2 or 3, now you're thinking, okay, is the hip center high? Do I need to bring it down, medialize it?
Yeah.
Crow 4, the most severe, you're almost certainly looking at needing a femoral shortening osteotomy to get the hip down safely.
Right, the severity dictates the complexity of the replacement.
Yeah.
What about implant choices in these DDH arthroplasties? Any specific recommendations?
Oh, definitely. This impacts long-term success. For the cup, generally, an uncemented cup is preferred.
Yeah.
Cemented ones historically had higher loosening rates in dysplastic bone.
Uncemented cup, okay.
For the stem, often a cemented stem is actually recommended. Why? Because it gives you more freedom to adjust the version, the rotation, intraoperatively.
Right.
The native femur is often weirdly anteverted, so you need to correct that.
Ah, allows version adjustment.
Exactly. And be prepared for a small stem.
Yeah.
Canals are often narrow in DDH, but there's a big exception. If you are doing a subtrochanteric osteotomy during the replacement, then the recommendation flips. You want an extensively coated, uncemented long stem that bypasses that osteotomy site by at least 2 cortical diameters. Gives you solid distal fixation.
Okay, that's a crucial distinction. Uncemented long stem if you cut the femur. Let's dive into those complex primaries more, especially Crow 23. These sound really challenging. What are the key pre, intra, and post-op things to think about?
They absolutely demand meticulous planning. You really have to think about the acetabular side and the femoral side separately.
Okay, let's start with the acetabulum.
Right. The biggest decision is the hip center. Are you going to restore the native center, where it should be, or accept a high hip center?
And what are the pros and cons there?
Well, restoring the native center is generally the goal, but it's tough in dysplasia. The anatomy is altered. Using the TL, the transverse acetabular ligament, as a guide helps find the true socket floor. Accepting a high center. Well, it avoids maybe needing a femoral osteotomy, but it has downsides.
Like what?
Increased shear forces on the implant, you often have to use a smaller cup, and patients can end up with a limb length discrepancy and a limp. So we try for native CR.
Got it. What about getting the cup covered? The roof is often deficient, right?
It is. But initial stability comes mostly from the anterior and posterior columns. You generally want at least 65% coverage of the hemisphere. If you can't get that, then you need augmentation. Maybe using the patient's own femoral head as an autograft, fixed with screws, or using metal augments.
Okay, acetabular planning sorted. What about the femoral side in these complex cases?
Okay, the femur. It's typically small, narrow canal, often very anteverted. As we said, cemented stems with DDH-specific designs often work well here.
Right.
Now, the osteotomy. You really consider that if you need to bring the hip down more than about 4 centimeters?
4 centimeters is the rough guide.
Yeah, it's a ballpark figure. If you need more length than that, the sciatic nerve starts getting unhappy. So you shorten the femur to allow the reduction without excessive nerve stretch.
And the osteotomy options.
Mostly subtrochanteric. That's the common one. Some use a trochanteric osteotomy, like Pavilionian described. I personally prefer subtrochanteric. You can use the resected bone piece as an onlay graft, too.
And if you do plan an osteotomy?
Then, as we said, preoperatively, you plan for that uncemented, extensively coated long stem to bypass it. And post-op, after any big downward shift, meticulous sciatic nerve check is absolutely mandatory. Cannot stress that enough.
Absolutely. You mentioned the femoral shortening osteotomy types, just to recap.
Yes, subtrochanteric is the most common. And then there's the trochanteric osteotomy, the Pavilionian technique.
And for the acetabulum, again, just to be clear, when is that lateral augmentation really needed? You said 65% coverage.
Right. If you can get 65% coverage with good press fit in the front and back columns, you often don't need roof augmentation. The primary stability isn't solely reliant on that often deficient roof.
Okay. This brings us back to that hip center debate, high versus native. It sounds controversial. What are the core arguments residents need to grasp?
It is controversial, but yeah, the consensus leans towards restoring native seed core if you possibly can.
Why is native better, despite the difficulty?
The biomechanics are just better. Less shear force, like Bicanic showed. Allows a larger cup, better range of motion, less risk of long-term loosening, and avoids that persistent LLD and limp.
But high hip center has some advantages.
It does. You avoid the complexity, potential non-union risk, and nerve risk of a subtroch osteotomy. You avoid needing bone graft. So if restoring the native center seems impossible or excessively risky in a particular case, a high hip center is an option. You just accept the compromises.
So native is gold standard, high is a fallback with known downsides. How do you achieve native COR then if it's so challenging?
Often involves careful reaming, sometimes medializing the cup deeper into the pelvis if the bone allows, and potentially using structural allograft for that lateral augmentation if needed to get enough coverage at the right height.
Right. Okay, one common question I hear. If you bring the hip down and shorten the femur with an osteotomy, doesn't the leg end up shorter?
That's a great point. Easy to get confused. Yes, the bone itself, the femur, is shorter than its original dysplastic length. But, and this is key, the limb, relative to the pelvis, ends up longer than it was just before surgery. Because the amount you shorten the bone is less than the distance you bring the hip down. So you gain overall functional limb length and equality, even though the femur itself was surgically shortened to allow that.
That clarifies it perfectly. Just a quick pause here to remind everyone listening, this whole deep dive is drawing heavily from the fantastic Ortho-made simple notes, which you can find over at mokyingren.sg. Really useful stuff. Okay, we've tackled the dysplastic hip thoroughly. Now let's shift gears. What about hip pain that isn't frank dysplasia, but more that mechanical conflict, femoral acetabular impingement, or FAI? Let's get into that. What are the two main types and what's the etiology?
Right, FAI. Two main flavors here. First is CAM impingement. That's a femoral-based problem, basically an abnormal bump or shape at the head-neck junction.
The bump on the ball.
Exactly. It can be idiopathic, just develops that way.
Yeah.
Or secondary to something like Pertez, causing a cosa magna, or maybe a healed SCFE, or even trauma, messing up the head-neck contour.
Okay, that's CAM. And the other?
The other is pincer impingement. This is an acetabulum-based problem. The socket is too deep or covers too much of the femoral head, especially anteriorly.
Overcoverage by the socket.
Precisely. Again, can be idiopathic or secondary to things like subtle DDH that's actually retroverted, or trauma causing overcoverage, maybe even iatrogenic from a previous surgery.
Got it. Cam on the femur, pincer on the acetabulum. What are the classic clinical signs? How does FAI usually present?
Clinically, the hallmark is pain, usually deep groin pain, especially at the limits of motion. For anterior impingement, which is the most common, the classic test is the FADR test.
FAR, flexion, adduction, internal rotation.
That's the one. Reproducing their pain with that maneuver is a strong indicator. For posterior impingement, which is less common, the Faber test flexion, abduction, external rotation might be positive. Patients often complain about pain with prolonged sitting or during sports involving deep hip flexion.
Okay, pain on FAR mostly. Now, x-rays. Again, just as critical here. How do we properly read an x-ray specifically looking for FAI features? Any pitfalls?
Yeah, reading FAI x-rays needs a system. First, and this is crucial, make sure the pelvic XR is properly centered and not tilted. Check the obturator foramen equal, check the symphysis alignment, check the coccygeus position relative to the pubis. Tilt can totally throw off your assessment.
Centering first. Got it.
Then, look specifically for those signs of acetabular retroversion we mentioned before, the crossover sign, the visible ischial spine sign. Those indicate potential pincer from retroversion.
Crossover and ischial again.
Yep. Then look for other signs of overcoverage, like coxa profunda, or even acetabular protrusio, where the socket is really deep. And for CAM, look for that pistol grip deformity, that loss of the normal concave waist at the femoral head-neck junction.
Pistol grip for CAM. Okay. Are there any special x-ray views that are particularly useful for FAI?
Yes, definitely. The done lateral view is really important. It's taken with the hip flexed, usually 45 or 90 degrees, with some abduction and neutral slight internal rotation. This view profiles the head-neck junction beautifully for assessing CAM lesions and measuring the alpha angle.
Done view for the alpha angle? Anything else?
The false profile view, that standing view with 65 degrees rotation, is great for assessing anterior acetabular coverage and measuring the anterior CE angle. Helps quantify pincer component.
Okay, done in false profile. You mentioned the alpha angle. What's considered abnormal for CAM SAI? What value are we looking for?
The alpha angle, measured on that done view, quantifies that bump. You draw a line from the head center, another along the neck axis, and see where the head outline deviates from a perfect circle. An angle greater than 60 degrees is generally considered abnormal, indicating a significant CAM lesion.
Over 60 degrees. Simple enough. Now, beyond x-rays, what imaging imaging helps in the FAI workup, especially if you're considering surgery?
CT scan, maybe with 3D recon, is excellent for really defining the bony morphology, especially for planning any bone reshaping and osteochondroplasty.
CT for bone detail.
Right. And an MRI, or MR arthrogram, is crucial for looking at the soft tissues. It assesses the articular cartilage damage, checks the labrum for degeneration or tears, and can show cysts. Tells you about the extent of the damage inside the joint.
MRI for cartilage and labrum. Makes sense.
Sure.
Okay, finally, management of FAI. What are the options on the table?
It usually starts non-operatively. Physical therapy is key, focusing on improving hip mechanics, core stability, modifying activities, trying to work within a pain-free range.
PT first.
If that fails, or for significant structural issues causing symptoms, then surgery is considered. Arthroscopy is the most common. You can repair or debride the labrum, reshape the bone, both the CAM lesion and any pincer rim trimming.
Hip scope is common. Other surgical options?
For really large or complex deformities, sometimes an open hip dislocation approach is needed for better exposure. If there's significant underlying dysplasia contributing, maybe a periacetabular osteotomy. And if the joint is just too far gone, too much arthritis, then joint replacement is the end-stage option.
Is there actually good evidence comparing PT versus arthroscopy? That seems like a key decision point.
Yes, there is. And residents absolutely need to know about the UK Fashion trial. It was a big multi-center RCT published in The Lancet back in 2018.
Fashion trial, what did it show?
It clearly showed that for patients with confirmed FAI morphology and symptoms, arthroscopic surgery led to significantly better improvements in pain and function at 12 months compared to a personalized physical therapy program.
So good evidence favoring surgery if PT fails for the right patient.
Exactly. It supports addressing the underlying mechanical problem surgically when conservative measures aren't enough.
And if you do need that open hip dislocation for a complex case, what's the standard approach?
The standard workhorse approach for that is the Gans trochanteric flip osteotomy. It involves carefully detaching the greater trochanter to allow safe dislocation of the hip, giving wide access while crucially preserving the blood supply to the femoral head.
The Gans approach. Got it. Okay, so we've covered a huge amount of ground dysplasia, FAI, anatomy, imaging, complex management decisions. What does this all really mean for you, our listeners, as you prep for exams and look towards practice? It's clear these aren't simple conditions.
No, they're definitely not. And that's the main takeaway, I think. Understanding these details, the angles, the classifications, the pros and cons of different surgical strategies, like native versus high hip center, the evidence-like fashion, it's not just about passing an exam. It's about building that deep clinical reasoning, being
Yeah.
able to look at a patient, their history, their films, and critically think through their specific anatomy and the best path forward for them. That's what leads to good outcomes.
Thinking critically about the pathways we've discussed. And remember, this deep dive was built on those really helpful Ortho Made Simple notes, which you can find at mokyingren.sg. Definitely check them out.
Yeah, great resource.
As you continue on your journey, preparing for these big exams, keep pushing your understanding. Keep asking why.
Absolutely. And as you do, may you find real strength and wisdom in your work. May God bless your hands with skill as you operate, your minds with clarity as you diagnose, and your hearts with compassion as you care for your patients. May your dedication truly be rewarded, both in seeing your patients improve and in the deep satisfaction of your calling.